My name is Lindsey De Lott. I'm a neuro-ophthalmologist at the University of Michigan and assistant professor with joint appointments in the Department of Ophthalmology and Department of Neurology. My work focuses on the design of evidence-based interventions that support patient-centered models of care. It takes, on average, about 17 years for research to make its way from clinical studies into the clinics. In eye care, this results in preventable vision loss and disability. I'm currently using acute demyelinating optic neuritis as a model for this work. Optic neuritis is a condition that affects approximately 4 per 100,000 people annually in the US. When patients develop optic neuritis, the eye becomes painful with eye movement, and the vision loss can vary from mild to severe and complete loss of vision. Although it is not a common condition, it is the ideal model for understanding how to design evidence-based patient-centered interventions so we can get the right treatments to the right patients. Over 20 years ago, the optic neuritis treatment trials showed that for the average patient with the most common types of optic neuritis associated with multiple sclerosis or without a clear cause following the appropriate workup, there was no difference in long-term visual outcomes among patients treated with high-dose intravenous corticosteroids compared to those who were not treated. Most patients spontaneously recovered vision over time, regardless of treatment. The only observed benefit was that the average patient who was treated with steroids experienced a hastened recovery at 2 weeks. However, over half the patients in the trial treated with steroids experienced a side effect, such as mood disorder or sleep disorder, but life-threatening side effects were rare. As a result, the investigators recommended a patient-centered approach to care that emphasized shared decision-making. In the year since the trial was completed, steroid use has remained universal. This suggests that shared decision-making is not routinely occurring. In qualitative interviews we performed with 22 clinicians who treat optic neuritis patients, we found that one important barrier to shared decision-making is that clinicians feel like they do not have the information that considers individual patient characteristics, such as the severity of the vision loss at onset, and how those individual characteristics might work together to influence long-term recovery or likelihood to experience a faster recovery with treatment. Personalizing clinical trial information is one strategy used to address this common barrier. Personalized risk and benefit information can be incorporated into patient decision aids and may ultimately facilitate shared decision-making for optic neuritis. In our project published in JAMA Network Open, we took the first steps toward developing a patient decision aid for optic neuritis by personalizing the benefits of steroid treatment for individual patients with the most common types of optic neuritis. We performed a multivariable risk-stratified analysis of the optic neuritis treatment trial data to assess visual function at 15 days and 1 year at the individual patient level. We used subset linear regression models for patients with baseline visual acuity that could be measured with an eye chart and separate models for patients with a visual acuity that was so poor it could not be measured with an eye chart. One example of this would be patients who could only see light or motion. Our study resulted in 2 main findings. First, the only predictor of visual acuity long-term was the severity of vision loss when the episode started. To put this finding into context, the regression coefficient from our model translates into only a 3-letter difference in visual acuity at 1 year between steroid-treated and no steroid treatment groups. A 3-letter difference is not a clinically significant change detectable by most patients. Second, as expected from the initial optic neuritis treatment trial analysis, we found that patients who received steroids had significantly better vision at 15 days. However, again, when we translate the regression coefficient to actionable information, it equates to about a 10-letter difference in visual acuity at 15 days for patients who were treated with steroids compared to those who were not treated. So what might this look like in the real world? Well, for patients with an average amount of vision loss from optic neuritis at the level of approximately 20/60, their vision at 15 days would be 20/18 if they took steroids versus 20/23 if they did not take steroids. This is a small difference in vision that may or may not be detectable to some patients. So with this information in hand, we developed a table that can be used at the point of care to provide patients with information about their visual prognosis with or without steroid treatment. This table is published in our article and can be accessed by all clinicians, but as a reminder, it should only be used in patients with the most common types of optic neuritis, such as optic neuritis associated with multiple sclerosis. We're currently finishing an analysis of national observational data to quantify serious harms for patients with optic neuritis treated with steroids compared to those that did not undergo treatment. The information from these studies will ultimately be incorporated into a patient decision aid to support shared decision-making. Patient decision aids like the one we are developing have been shown to increase patient satisfaction and improve patient health outcomes. We hope this project will provide a framework for designing similar interventions to support evidence-based, patient-centered care for other eye-related diseases.